25 most important questions for anesthesia for your FMG exam. Well, we definitely expect that one few questions comes from this, right? From this session as well. So let us start our discussion with the first question. And the first question is, a 48 years old female is hypertensive from last 5 years on regular medication, is posted for laparoscopic hysterectomy. In pre-anesthetic evaluation, she gave history that she is able to climb free flight of stairs with no problem. She will be put in ASA classification. So this is a topic from a very important topic, which in pre-anesthetic evaluation, which I expect would definitely be coming in the exam, and that is ASA classification. So what is this ASA classification? Now, ASA classification is something which we do in pre-anesthetic evaluation of our patient. This tells us about the risk associated with surgery. Risk associated with surgery, right? And we have 6 ASA grades, right? We have ASA grade 1, 2, 3, 4, 5, and 6, right? And we need to be crystal clear that how the patients are graded in these six grades. ASA grade 1, well, if patient doesn't have any comorbidity, right, we put them in ASA grade 1. Okay, so ASA grade 1 means no comorbidity. Patient has no other comorbidity apart from what the patient has come to get operated for. Okay, so we have to see that patient doesn't have any comorbidity. If patient doesn't have any comorbidity, patient is in ASA grade 1. Okay. ASA grade 2, patient has comorbidity, but it is a thoroughly controlled comorbidity. So, controlled comorbidity. So, patient has a controlled comorbidity. And what kind of illness comes in ASA grade 2? Mild to moderate systemic illness, right? And ASA grade 3, comorbidity with moderate limitation, some limitation in the physical activity. So, comorbidity with limitation. So, comorbidity with limitation is in ASA grade 3. And ASA grade 4 is life-threatening comorbidity. Patient has life-threatening comorbidity. So, ASA grade 4 is life-threatening comorbidity. Okay. So, these 4 ASA grades are very important. And if I put the systemic illness in this, I have written it like this. I just want to say ASA grade 1, I said no comorbidity. 2 means your mild to moderate systemic illness. Mild to moderate systemic illness. Right? Mild to moderate systemic illness. Very nice. ASA grade 3 means moderate to severe systemic illness. Moderate to severe systemic illness. ASA grade 4 means life-threatening. Life-threatening. Very good. So, if I put my first question in this, patient is hypertensive from last 5 years on medication, right? On medication, right? And in pre-anesthetic evaluation, she gave the history. She's able to climb 3 flights of stairs with no problem. So patient has no limitation in his or her physical activity. So this patient will belong to ASA grade. Yes, everyone, please answer. I want to see few answers in the chat box. 2 or 3. So patient has a comorbidity, and comorbidity is not causing any physical limitation. She can climb 3 flights of stairs. So she can climb 3 flights of stairs. Hello, Shinawaz. I'm very good. Thank you. Thank you for asking. Can you tell me the answer of this question? Happy New Year. Happy New Year to everyone. And may this New Year bring a very, very good result for all my dear students. I know you will come out with flying colors. Okay. So most of you are answering correctly. It is 2, 2, 2, 2, 2. Absolutely right. It is ASA grade 2. ASA grade 2. Okay. So this patient is ASA grade 2 because patient is able to carry out an activity without any issues. So patient has a controlled comorbidity, and controlled comorbidity means mild to moderate systemic illness. Okay, guys. Again, I want to clarify again one more thing, that if it is written mild to moderate systemic illness comes under which ASA grade, your answer has to be ASA grade 2. If they only ask mild systemic illness, again answer will be 2. If they only ask moderate systemic illness, answer will be 2 again. So for mild alone, moderate alone, answer has to be 2. For 3, the severe word has to be attached. So moderate to severe would be the ASA grade 3. Only severe would also be ASA grade 3. Okay. And for 4, it should be life-threatening systemic illness, right? So 4 should be that patient is not able to carry his normal activity also. So if I modify this question, few more question I can make. So in pre-anesthetic evaluation, she gave history. She's unable to climb 3 flight of stairs. So I'm changing the question to unable to climb 3 flight of stairs. Then the answer would become ASA grade 3. And if I put in the question that in pre-anesthetic evaluation, patient is not able to speak without pauses, cannot walk without support, or cannot, without taking breaks. Patient is unable to breathe properly, unable to speak properly, unable to carry out his normal activity, then the patient will belong to ASA grade 4. Got my point, everyone? So unable to carry out his normal activities would become ASA grade 4, right? Can carry out activity, right? Can carry out activity, but becomes symptomatic in the process, then it is 3. And can carry out the activity without any issue, then it is 2. Okay, very nice. And no problem in carrying out, and there is no comorbidity, then it is ASA grade 1. So I hope ASA grade 1 to 4 is clear. 5, some of you have already answered. 5 means surgery is the only option for survival. Surgery is only option for survival. Okay. So again, I'll talk about Venkatesh, 3rd. Okay. And 6 is different from ASA grade 1 to 5. 1 to 5 are living patient, and 6 is brain dead patient. 6 is brain dead patient for organ transplantation. Okay. Okay. So 3, what I said, patient becomes symptomatic on activity, like climbing 3 flight of stairs or walking for 5 kilometer, and has a comorbidity and becomes symptomatic on some activity. Then the patient is 3, a systemic illness or moderate to severe systemic illness. Severe systemic illness or moderate to severe systemic illness will produce symptoms in the patient. Mild to moderate systemic illness will not produce any symptoms in the patient. Got my point? So you need to keep in mind, mild to moderate systemic illness will not produce any symptom. Okay? Got it? Now any more doubts? I hope Venkatesh it is clear. Okay, fine. So coming on the next question. Next question is again from a very, very expected topic, NPO guidelines. So in your exam, I see a lot of questions on NPO guideline. I know all my students must be at this point well versed with NPO guidelines. Wonderful. Okay. Harsh is asking, am I under which grade? Harsh, you cannot put a particular disease and ask me under which grade. It depends upon the functional capacity of the patient. Functional capacity. So if patient has a history of myocardial ischemia and the patient is stable at this point, having no symptoms, then the patient belongs to ASA grade 2. And myocardial ischemic patient on some activity like climbing 3 flight of stairs complains of chest pain, then the patient is your ASA grade 3. Got it? So remember, and patient has chest pain even at rest, then the patient is 4. I hope Harsh it is clear now. Yeah. So next question. A 25 years old primee posted for elective LSAS under spinal anesthesia. Which statement is correct regarding nilperoral? Yeah, all my dear students are telling me absolutely correct answer. Answer is NPO for 6 to 8 hours. Yes. NPO for 6 to 8 hours. Though I have tried to confuse you that spinal anesthesia, which is a regional anesthesia, that in spinal, patient does not become unconscious. So there should not be any requirement of NPO. But as we have already talked so many times, for elective procedure, irrespective of type of anesthesia, general or regional, we have to keep the patient NPO. The NPO guideline is same. The NPO guideline is same. Okay. Now, okay. Why Parikshit? Why 2 hours? Why 2 hours? See, guys, one thing very clear. If type of food is not mentioned, clear water is not mentioned, I cannot assume they have asked clear water. We have to go for NPO 6 to 8 hours only. And best answer would be 6 hours. NPO for 6 hours, because that is what we order to our patient. Take a light meal 6 hours prior to surgery, 6 hours prior to the scheduled time of surgery. Okay. So remember, for nil per oral guideline, nil per oral guideline, right? All patient, irrespective of type of anesthesia, has to undergo nil per oral prior to elective surgery. For adult, we have 8, 6, 4, 2. 2 for clear fluid. And what comes in clear fluid? Can anyone tell me? Water. I'm drinking my tea. Does it come under clear fluid? Let's say. Well, tea without milk comes under clear fluid. We keep it under clear fluid. We allow tea without milk. Got my point, everyone? So clear fluid means plain water, coconut water, tea or coffee without milk. Okay. Then 4 hours is only for pediatric patient, because pediatric patient, that is 4 hours is for your mother's milk, the breast milk. The child is on mother's milk. We ask the mother to give the milk 4 hours prior to surgery. And 6 hours for liquid and semi-solid food. Liquid and semi-solid food. Any kind of liquid and semi-solid food. Right? So we keep 6 hours NPO. And 8 hours NPO for your full fatty meal. Full fatty meal. Right? So keep it in mind. So this is your nil per oral guideline. Okay, got it? Okay. Now, guys, here in your pre-anesthetic order, I just want to talk about one more thing. In pre-anesthetic order, there is one thing which has been changed. I have taught so many students over so many years that any change in the guideline, if it comes, I need to tell you if a question is asked. Now, a lot of patient may be on your anticoagulants. So if a patient is on anticoagulants, okay, and the patient is, let's say, has been posted for any surgery, right? And patient had undergone stent placement, right? So stent placement patients are always on anticoagulants. They are on dual antiplatelet therapy, always. So previously the guideline was that if the patient has bare metal stent, if it is bare metal stent, then you need a gap of 1 month between stenting and surgery, between 1 month between stent and surgery, right? You need a gap of 1 month. And if it is a medicated stent, you need a gap of 1 year, right? This was a previous guideline. Now it has been changed. I'm writing it big. It is changed. Now, for any kind of stent, bare metal or medicated, you don't have to bother. We need a gap of 6 months to 1 year. So, any stenting done, medicated or bare metal, any kind of stent, we need a gap of 6 months to 1 year. We need a gap of 6 months to 1 year. Got it? So this you have to keep in mind. It has been changed. Previously, it was different for medicated stent and different for the bare metal stent. Now it is same. Okay, so keep it in mind. 6 months to 1 year. Okay, yeah. Now next question. Again, from a very important topic, and monitoring. So in monitoring, according to me, the most important topic is your capnography. Capnography. The most important topic is capnography. And this question I have picked up from capnography. Guys, we've just finished one topic, 2 questions of one topic. The topic was pre-anesthetic evaluation, PAC checkup. And in PAC checkup, there are 3 things which are important. Number 1 is ASA guideline. Number 2, the Mallampati. Mallampati, I've asked so many times questions on Mallampati. And your NPO orders. These 3 are most important. Now coming on next question, that is monitoring, next topic. And in this, capnography is most important. Okay. And what is the most probable diagnosis? First we need to discuss that what is this graph. This is very good. So Rashik has given me the right answer. Afzal has given me the right answer. This is shark fin pattern. So who will tell me that this shark fin pattern comes in which type of patient? Yeah. So options: endobronchial intubation, bronchospasm, embolism, malignant hypothermia. What would be the answer? Wonderful. The most of you are giving me the right answer. It is bronchospasm. So answer of the question is bronchospasm. Guys, capnography. Very fast. I will revise few expected questions from capnography. Normal value. Who will write in the chart box the normal EtCO2 value? The normal value is your between 35 to 45 mm of Hg. Right? This is the normal value. And normal graph is this. This is a normal graph. This is a normal graph. Right? And this graph represents one respiration, one respiratory cycle. Now this has phase 1, phase 2, phase 3 and phase 4. Phase 1 to 3 is representing your inspiration and phase 4 is representing, phase 1 to 3 is representing expiration, phase 4 is representing inspiration, right? So 1, 2, 3. Phase 1, if the arrow is like this and they ask what is this phase, your answer has to be dead space ventilation. Dead space ventilation. Phase 2, if the arrow is like this and they ask what phase is this, your answer has to be dead space plus alveolar, right? And phase 3, this was asked in NEET. I'm expecting this question can be asked in your exam. I just didn't repeat the same question because I have a plan to discuss it with you. So phase 3 answer is alveolar. And the phase 4 is your inspiration. Phase 3 is plateau and plateau rhythmic represents your alveolar ventilation. Okay. So this is very important, most important. Got it? Okay. Now few important graphs. If in capno, question says there is a sudden fall, what will be the answer? If there is a sudden fall, what will be the answer? Sudden fall. Or if there is a doubling, sudden increase, what will be the answer? Or if the pattern changes like this, right? Or if the baseline gets elevated. Okay. So what would be the first one? Sudden fall. Wonderful. Wonderful, Rashik. Wonderful, Atul and Harsh. It is embolism. So this is embolism. Sudden increase. Yes. Wonderful. Malignant hypothermia. Harsh, which is curatic left. I haven't made curatic left. So malignant hypothermia. This is malignant hypothermia, doubling of CO2. Which is curatic. Curatic left I haven't made. Yeah. This is shark fin, which was in my question. Shark fin. This is the graph. This is the shark fin I made. Okay. Okay. And this is CO2 rebreathing. CO2 rebreathing graph. When we are rebreathing the expired air. And shark fin pattern, which was asked in the question, represents partial obstruction. So any decrease in the caliber of the airway, there would be the shark fin pattern. And this would be in your COPD patient, your bronchial asthma patient, your bronchospasm patient, or ET tube obstruction, in ET tube obstruction patient, right? In all this, it could be possibility that we would get a shark fin pattern, right? So this question was shark fin pattern and answer is bronchospasm. In embolus, we would get a sudden drop. In malignant hyperthermia, we would get a increase. In endobronchial intubation, again, we will get a increase because the lung surface area of exchange has decreased, right? So in this also, endobronchial intubation, EgCO2 will increase, but not like malignant hypothermia, right? Okay, now guys, one important graph which someone mentioned, if this cleft appears in the graph, this is curare cleft. Curare cleft. And curare cleft means return of spontaneous ventilation. This means return of spontaneous ventilation. Return of spontaneous ventilation. So this is curare cleft. Got it? So keep it in mind. When this happens intra, we repeat a dose of neuromuscular blocking agent. Okay, very nice. So coming on the next question. Okay, which of the following tests is depicted in the following image? Again, a very, very popular, expected question. So what would be the answer? What would be the answer? Okay, very nice. Aarti has written the answer. It is Allen test. It is Allen test, right? So in this Allen test, this is Allen test, which we do to see the patency, between the superficial palmar arch, see the arterial arcade between two artery, median as your ulnar and radial artery. So this Allen test is done before putting the arterial cannula in the radial artery, before putting arterial cannula in radial artery, right? So we have to put the arterial cannula in radial artery. This artery can go into spasm. So we need to check the area supplied by this artery would get a proper let's say blood flow or not, and that depends upon the arterial arcade between radial and ulnar artery. And to see that, we perform the Allen test. So this show the Allen test is done to see the arcade between radial and ulnar artery, right? Radial and ulnar artery. So it is done. Yeah, even before ABG, we can do it to see the arcade, right? So you always have to see if there is pressure on radial and ulnar artery, right? And then they are asking if pressure on radial and ulnar artery, and then they are asking that what test is being performed, right? So what would be your answer? Answer has to be Allen test. Okay, answer has to be Allen test. Okay, and this Allen test can also be done with your, let's say, pulse oximeter attached to it. We can also do it with pulse oximeter attached with it. Okay, so if we attach pulse oximeter in this Allen test, then guys, this is called Barbeau test. Barbeau test. So I'm writing one more question with this. Same image. There is a pulse oximeter attached. Pulse oximeter attached. Then what test is being depicted in the image? The answer has to be Barbeau test, right? So we discussed two important tests: Allen test and Barbeau test. Barbeau test, right? Allen test and Barbeau test. Now both are done to see the patency between the arcade of arterial and radial and ulnar artery. So both is done before radial artery cannulation. right? Both is done before radial artery cannulation. And radial artery is the best site for intraarterial catheter. This is the best site which we use for intraarterial catheterization. Okay. And Barbeau test is done with pulse oximetry. Pulse oximeter. So this is one probable question. Why probable? Because when this question was asked in NEET, the Allen test, they gave Barbeau as the option. So here, instead of Addison, they had Barbeau as the option. And if just a pulse oximeter attached, the answer will change into Barbeau test. At present, without pulse oximeter, the answer is Allen test. Got it? Okay. Now, there are a few things in monitoring. I just single liner question, which I want you people to remember. We will revise. I will go on asking the question. You will go on telling me the answer. Right? Yes, Atul. Both are used to check the patency of radial and ulnar artery, the arcade between radial and ulnar artery, right? One is done with a pulse oximeter, that's Barbeau test. Allen test with pulse oximeter is Barbeau test, as simple as that, okay? Okay, guys, now just the most common nerve monitored during anesthesia. Most common nerve monitored during anesthesia or for neuromuscular monitoring. Any can be asked. Most common nerve during anesthesia and most common nerve used for neuromuscular monitoring. Yeah, the answer has to be your ulnar nerve. Then they can ask that most common site for core temperature monitoring. So what will be the answer? Most common site for core temperature monitoring. So I'm leaving this. You will tell me the answer. Then I will write another thing meanwhile. Then best site or most sensitive site. Most sensitive site for core temperature. Monitoring. So two questions I have asked. The most common site and most sensitive site. For both the answer would be different. Okay, next. The most sensitive monitor to diagnose air embolism. Most sensitive monitor to diagnose air embolism. And so many of you are giving me the right answer. Okay, wonderful. Most common site for core temperature monitoring, answer is lower 1/3 of esophagus. Lower 1/3 of esophagus. Okay. Then most sensitive site for core temperature monitoring, the answer is your pulmonary artery catheter. Most sensitive, it is pulmonary artery catheter. Okay. And most sensitive monitor to diagnose air embolism, answer is transesophageal echocardiography. Transesophageal echocardiography. Wonderful. So for all this, we have written the answer. Okay. Understood this? So this is your few important questions related to monitoring. And Shrivansh, rectum, for what you are answering me? Rectum. I mean rectum? Nowhere is the answer. Rashik, Capno would not be the answer for most sensitive monitor for diagnosing air embolism. Answer would be T. Most sensitive is T. In Capno, a sudden drop gives us idea of air embolism, but it is not most sensitive. For most sensitive, we have to answer transesophageal echocardiography. Got it? Okay, next question. An adult on controlled mode of ventilation required a Mapleson circuit to be attached. Which circuit should be chosen? Okay, so guys, I'll come back on the question. What are the possible questions from Mapleson? Mapleson has been asked in last NEET and exam. So I'm expecting in INI-CT, there was also a question. There could be a question which can be asked on it. So Mapleson, we have Mapleson A, B, C, D, E, F. Okay, some of you are answering A and some of you are answering D. 2. There shouldn't be any doubt, guys. There should not be any doubt in this. Okay, we have Mapleson A, B, C, D, E, F. A to D. This is adult. This is used for adult. ENF is used for pediatric, right? Okay. A is in adult, best circuit for spontaneous ventilation. Best for spontaneous, right? Spontaneous ventilation. If patient is ventilating spontaneously. And A is also called Magel circuit. Magel circuit. B and C is not used in clinically, so we don't have to know anything about it. Okay. D is also called Bain circuit. It is also called Bain circuit, and D is best for controlled ventilation. Best for controlled ventilation. So D is best for controlled ventilation, right? So in adult, A is best for spontaneous, D is best for controlled ventilation. ENF is pediatric. E is also called IRs TPs. IRs TPs. And it is bagless, valveless, useless. I said it is bagless, valveless, and useless. It was made useful in the form of F. So F was made useful by a person called Jackson Rees. So Jackson Rees. So Jackson Rees circuit is F, or we call it JR circuit. And this is the use for pediatric anesthesia. So for pediatric anesthesia, which was asked in last exam, answer is circuit F. Answer is circuit F. So guys, in an adult on controlled mode of ventilation, which circuit should be attached? Answer has to be D. So D is the best circuit for controlled ventilation. Got it? So again, very quickly remember, F is modified Mapleson E. It is modified Mapleson E, and it is used in pediatric anesthesia. And it is modified Mapleson E. Okay? Yeah. If we see controlled ventilation, the best circuit is D, followed by B equal to C, followed by A. So again, one more question. A is worst for controlled ventilation. Worst for controlled ventilation. D is best for controlled ventilation. Okay. For spontaneous ventilation, best is A, followed by D, followed by B equal to C. So guys, remember, A is best for spontaneous ventilation and D is second best for spontaneous ventilation. Got it? So D is a good circuit. D is also called Bain circuit. We always keep D in our operation theater, right? Okay, so this is all about our Mapleson circuit. Any question asked on Mapleson circuit would be covered from what we have just now discussed. So this is all about Mapleson circuit. Coming on the next question. All of the following statements are true about the device in the image except. First, you need to recognize the device in the image. So I'll wait for your answers in the chat box. What is the device in the image? And meanwhile, I would just read the question. Options. A is, this is second generation supraglottic airway device. Okay. The cuff of the device is non-inflatable. Okay. It cannot be used for laparoscopic surgery. Okay. There's a gastric drain present in the device. Okay. What would be the answer? Wonderful, wonderful. All of you are giving me the right answer. This is iGel airway, which is a second generation supraglottic airway device, right? Wonderful. This is second generation supraglottic airway device, right? This is second generation. No, Varun, not third generation. This is second generation. This is no Shivans. This is iGel. I will tell you about LMA Supreme in a second. But this is iGel, second generation supraglottic airway device. This cuff is special. Cuff of iGel is not inflatable. It cannot be inflated. Non-inflatable. So this is a special cuff which swells on its own. It is non-inflatable, right? Now, it has this airway tube and it has this gastric drain present in it. Okay, so it has two tubes, airway and gastric drain. So airway tube and gastric drain. And through this gastric drain, we can deflate the stomach of the patient also. So what is the wrong? All the statements are true except. Okay. Then this is second generation supraglottic airway device. This is true. The cuff is non-inflatable. This is true. It cannot be used for laparoscopic surgery. Guys, all second generation can be used for elective surgery with more risk of aspiration also, because they are comparable to ET tube in preventing aspiration. ET tube in preventing aspiration. So they can be very well used for laparoscopic surgery. So this is a false statement. There's a gastric drain present in the device. This is true. So which is a false statement? C is the false statement. Got it? So this is an important question, and I'm expecting image-based question on IGEL. Guys, supraglottic airway device. Supraglottic airway device, right? So supraglottic airway device is very important from exam point of view for the question. Is divided into two types. The first and second. Third generation, manufacturer are naming something called third generation. But guys, remember, third generation, I mean, in books, it is still not getting mentioned. Yeah, but there are some devices like Busca airway, etc., which comes under third generation. Okay. Okay, guys. So supraglottic airway device, first generation and second generation. Second generation, right? First and second generation. Okay. First generation, example, classical LMA. Classical LMA. This is the prototype device of first generation. Then Cobra perilaryngeal airway. Cobra perilaryngeal airway. So this is also first generation. Then Ambu 40. This is also first generation, right? Okay, guys. Then second generation, the ProSeal LMA. Then your Ambu Aura Gain. Then your IGEL airway, and your LMA Supreme. So these are the important, your second generation. Names are important. You need to remember the name. Ambu 40 has been asked. Ambu Oragen has been asked. LMS Supreme is in the options when these questions were asked. So which is second generation, which is first generation, you have to remember. Remember, first generation and second generation I am talking about. First generation has only one tube. It has only one tube, and that tube is ventilation tube, airway tube. Second generation has two tube. One is airway and other is gastric tube. Okay. Then first generation has only one cuff. Second generation has two cuffs. Second generation has two cuffs. First generation has one cuff. Then let's say I said two tubes, two cuffs, and two works. First generation is only used for ventilation, and second generation is used for ventilation, and it is also used to deflate the stomach. Because here we can even put Ryle's tube through it. And what is the best thing about second generation? These are comparable to ET tube in preventing aspiration. Comparable. So small request has been made to me by Dr. World to write clearly. Sorry, buddy, I'm a doctor. Doctors cannot write clearly, but I'll try my level best because I'm a teacher at now. Right? So comparable to ET tube in preventing aspiration. So comparable to ET tube in preventing aspiration. Got it? And first generation cannot prevent aspiration. First generation cannot prevent aspiration. cannot prevent aspiration, right everyone? So you have to know these two things about first and second generation. Very, very important, guys. Okay, everyone, please focus on very important thing. Your LMA ProSeal, LMA ProSeal. I have not put the image because I want to draw it and make you understand it. We'll have a cuff like this. We'll have a airway tube, and we'll have a side gastric tube which will end on the tip. This is LMA ProSeal. This would be straight device. If I curve this at an angle, so this is the airway tube, this is the cuff, and this is the gastric tube which is ending on the tip. Now this becomes LMA Supreme. This is LMA Supreme, which is 45 degree, bent at 45 degree. It is bent at 45 degree. Okay. Eye gel is entirely different from both because this has a, okay. Eye gel is completely different because these have inflatable cuff. We have to inflate it. So we have a pilot balloon system to inflate it. So both have pilot balloon system to inflate it, right? But your eye gel, I have shown you, it has a non-inflatable cuff. It doesn't have a pilot balloon. It has no pilot balloon to inflate it, right? It has a non-inflatable cuff, right? So keep it in mind. For ProSeal, there would be two tube and there would be inflatable cuff. For LMS Supreme, it will be bent at 45 degree. Same, it will look like ProSeal, bent at 45 degree. And it will also have two tubes and inflatable cuff. And your eye gel will have non-inflatable cuff. These all are second generation. Classical LMA will just have one cuff and one tube. This is classical LMA. Keep it in mind. This is classical LMA. Cobra perilaryngeal airway would be like this. Just would have another cuff here. Then it would be Cobra perilaryngeal airway. Okay. So your classical LMA doesn't have this cuff present here, which is present in the Cobra perilaryngeal airway. Right. So keep in mind for remembering these devices, this important image. Okay. Now next question. Again, a very expected question. So many times it has been repeated in your exam. I am again repeating it. There is increased resistance to breathing through endotracheal tube, predominantly due to diameter of the tube, length of the tube, material of the tube, curvature of the tube. So we know that resistance is inversely proportional to the radius power of 4. So this is a tube. When a fluid or a gas flows through the tube, the tube offers resistance. When the gas flows through it, tube offers resistance. And this resistance, right, depends upon the radius of the tube, right, to the power 4. So this is, let's say, the cross section of trachea, and this is cross section of trachea with tube. So this is the diameter of the trachea, and now this is the diameter through which the patient is getting the gas is passing, right, because of the tube present in the trachea. So diameter has reduced, diameter decreased, radius decreased, resistance would increase fourfold, and work of breathing will increase. So answer is diameter of the tube, and all of you have given me the right answer. You know, this is one question which I have seen at least 3 times being repeated in FMG clearance exam. It can be repeated again. That's why I have purposefully put this question. So keep it in mind. It is diameter of the tube. Okay, next. Which grade of laryngeal view according to Konmark-Lehane grading? Now guys, I have not given Mallampati this time because somehow I have a hunch that all the questions for Mallampati has been asked repeatedly. So they can ask another grading system of the airway, and that could be Konmark-Lehane grading system. But remember, this is entirely different from Mallampati grading system. This is not pre-anesthetic evaluation. This is laryngoscopic view. As we can see, this is the larynx. This is larynx. This is the larynx. Okay. So what is the Konmark-Lehane grading system? Konmark-Lehane grading system. Okay. Yes, so many of you are giving me the right answer though. We have discussed actually Konmark-Lehane grading and how it is different. How it is different from Mallampati, from Mallampati, from MMP grading, right? So guys, Konmark-Lehane grading system is laryngoscopic view of glottic opening. So when we do the laryngoscopy, the laryngoscopic view of glottic opening is what is Konmark-Lehane grading. How it is different from Mallampati grading? It is not done in PAC, not done in pre-anesthetic checkup. So it is not a PAC checkup thing. Okay. What is similarity to Mallampati? Both predict difficult airway. Similarity is, what is the similarity? So similarity is both predict difficult intubation. Both predict difficult intubation. Right? Now let us talk about Konmark-Lehane grading. Right? If I do the laryngoscopy, an entire glottic opening is seen, we write grade 1. If only the posterior part of the glottic opening is seen, only this much is seen, then we write grade 2. And if only the epiglottis is seen, we write grade 3. And only the hard palate, we write grade 4. So in 3 and 4, we are not able to see this opening. So how we will put the tube? So this becomes difficult intubation. And these can be done easy. So this is no difficulty, right? So this is telling us about difficult intubation, and this is the laryngoscopic view. So only if posterior half is seen, it is Konmark-Lehane grade 2. Let us see the image, keeping this in mind. So what is here in image? This is the what is this? This is the epiglottis, and we have lifted up the epiglottis, right? And we have lifted up the epiglottis, and we are not able to see the entire glottic opening. Some part of the glottic opening is covered with this epiglottis. So this is your grade 2. Remember, if entire glottic opening was seen, it was grade 1. If this was not seen, no chink was seen, only epiglottis, then it was grade 3, that is C, and only hard palate, then it was grade 4. Got it? So keep it in mind. Now here only I will discuss little bit about Mallampati grading also. My Mallampati, all the question has been exhausted, except they can give image of one, let's say single images of Mallampati and ask which Mallampati grade it is. Guys, now this is your mouth, this is the tongue out, right? And if I am able to see all the structures, I can see all the structures of the mouth. I can see the hard palate, I can see the soft palate. I will drop it again and make the diagram again. So this is the tongue, and above the tongue I can see the hard palate, I can see the uvula, and I can see the soft palate. I can see the tonsillar pillars, I can see the fauces, everything I can see. Then we write Mallampati grade 1. If this is the tongue, right, and tongue is little bigger, I can see the hard palate, I can see the soft palate, I can see the tonsillar pillars, but fauces are hidden behind the tongue. Then I write Mallampati grade 2. Now guys, this is the hard palate. Now this is the soft palate, right? And the tongue is now big enough that it is even obscuring the tip of the soft palate. It is obscuring even the tip of the soft palate. Then it is Mallampati grade 3. If this tip is not seen, here the tip is seen, right? The tongue is only this much. I can able to see the tip. But here the tongue is this much. I am not able to see the tip. Then it's 3. And if this is the hard palate and the tongue is very big, obscuring all the structure, tongue is still here, then it is Mallampati grade 4. Okay, so individual they can ask. So 2 grading is important for exam point of view, 2 and 3. For 2, the entire uvula will be seen, and in 3, only the base of the uvula will be seen. Tip of the uvula will not be seen, right? So tip of uvula not seen. Tip of uvula not seen. Not seen in grade 3. And in grade 2, tip of uvula seen. Tip of uvula seen, right? And 4th grade, only hard palate. Only hard palate seen. Nothing else. Only hard palate is seen. Got it? And grade 1, everything seen. Okay? So these are the important things which which is, let's say, we have to keep in mind. Okay? Okay. Next question. So I talked about ProSeal LMA. ProSeal LMA, right? I showed you, I made the image of ProSeal LMA. This is the ProSeal, LMA ProSeal, isn't it? In which I made one gastric tube, one airway tube. Now I will show the image. I will show the image of the ProSeal LMA. So now this question, the diagram of ProSeal type laryngeal mask airway is provided, which is true information about the device. So now in this question I have asked only one true, right? Right? One true. Okay. So this, as you can see, has a cuff, has a airway tube, and has a gastric tube. Gastric tube. Okay. This is the gastric tube. So this is the airway tube, gastric tube, and entire device is straight. It is not curved. If it was curved like this, it would have been the LMA supreme. This is LMA supreme. So this is straight. This is 2nd generation supraglottic airway device. Well, this seems the true statement. This is true. Cannot be used for elective surgery. This is false. I can use any LMA device for elective surgeries, right? 2nd generation can even be used for surgeries where there is a risk of aspiration because they are comparable to EG tube in preventing aspiration. Tip remains above the glottic opening. Who will write in the chat box? Where does this tip, I have made an arrow also. Where does this tip of the LMA lies? Where is the tip? Where is the tip? Anyone can write in the chat box. Where is the tip? 4th option is cannot be used in children. Guys, all sizes available. This is also false. This is also false. The tip does not remain over the glottic opening. Yes, tell me. So this is the true option. This is the true option. So where does the tip remain? So if we see a supraglottic airway device, we insert it. Now this is the cuff. Now this is the airway tube, and airway tube opens. There is another opening for the other end of the airway tube. This open on the ventral part of the cuff. Ventral part of cuff, right, of the mask. Yes, and this is against the glottic opening. Where does the tip lies? Tip is on esophagus. Tip, this is the tip. The tip is on esophagus, or in hypopharynx, for all supraglottic airway device, hypopharynx. Guys, if it was LMA Classic, the tip didn't had any opening in it. But in LMA ProSeal, tip has an opening. Through this gastric tube, we can put a Ryle's tube and we can even deflate the stomach. So it will lie on the esophagus. Then only we can put the Ryle's tube through the gastric tube. Okay, because gastric tube runs throughout the cuff till the tip. This is the gastric tube, and we put a Ryle's tube through this opening on the tip, and this tip is on esophagus. In LMA Classic, we have a blind tip. In LMA Classic. Because there is only one tube for ventilation. There is no gastric tube. Got it? So keep it in mind. Tip is always on esophagus. Okay, guys. Now, cannot be used for elective surgery. Remember that LMA indication, the reason why LMA came into clinical practice was to secure the airway in difficult airway, right? Okay. To secure airway in difficult airway situation, right? This was the first indication of putting LMA, of requiring LMA, right? Second was during elective surgery, we can use LMA. Now, classical LMA, we only use when there is no risk of aspiration. No risk of aspiration. Simple, simple surgery. But your second generation like ProSeal LMA, we can use for any elective surgery, even lap chole, everything. So we can use for any surgery. We can use for any surgery less than 2 hours duration. We can use for any surgery, the second generation. So that was the another indication of your putting LMA. And the third was a special LMA was designed that was called intubating LMA. Intubating LMA. Now this intubating LMA, or we call it fast track LMA. This was used to put tube. This was used to put tube, endotracheal tube through the LMA. So these are the 3 indication of putting LMA. Got my point? Okay. So these are the indications. So we can use it during elective surgery. Cannot be used in children, guys. It can be used in both adult and children. So LMA, all sizes for all age group. All sizes for all age group available. Right? So the sizing of the LMA is decided according to body weight. Now, please put valid things in the chat box, right? Okay. So weight in kg, size. Weight in kg, size. So less than 5 kg, 1. 5 to 10 kg, weight, 1.5 size. 10 to 20 kg, 2. 20 to 30 kg, 2.5. 30 to 50 kg, 3. 50 to 70 kg, 4. More than 70 kg, 5. And more than 100 kg, it is 6. So we have 8 sizes available for your classical LMA, for all LMA, for classical LMA, for PLMA, for iGel, for LMA Supreme, for all, we have all sizes available. Okay. Now coming on the next question, 10th question. Which of the following is not a low flow variable performance oxygen delivering device? Low flow variable performance oxygen delivering device. Right? Okay. The rebreathing mask, Venturi mask, face mask, nasal cannula. So guys, oxygen delivering device, very important topic. Right? So oxygen delivering device can be divided into 2 types. Low flow variable FiO2, low flow variable FiO2, and high flow fixed FiO2, high flow fixed FiO2. In low flow variable FiO2, so many of you are giving me the answer. Some are giving right, some are giving wrong. So low flow variable FiO2, 3 devices comes under it. Nasal cannula, your face mask, and your rebreathing and non-rebreathing mask. Non-rebreathing mask. Rebreathing and non-rebreathing mask. Okay. These 3 devices comes under your low flow variable FiO2 delivering device. What comes under high flow fixed FiO2 delivering device? Venturi mask. Venturi mask. Very important device. Then your HFNC, high flow nasal cannula. High flow nasal cannula. So this is the second important device. Right? Okay, and third is your high flow fixed FiO2 delivering device, very important device, is your bag valve mask. That is your ambu bag. So these are 3 important high flow fixed FiO2 delivering device. Okay, so in this question, what would be the answer? Low flow. Rebreathing mask is low flow. Venturi mask is high flow. Face mask is low flow. And nasal cannula is low flow. So which is not low flow? Venturi mask. Venturi mask. So Venturi mask is high flow fixed FiO2 delivering device. Okay, keep it in mind. Venturi mask is high flow fixed FiO2 delivering device. And these are low flow devices. Low flow devices. Got it? Okay. Okay, guys. Next. Which of the following device will deliver FiO2 between 0.25 to 0.5 independent of patient's breathing pattern? So first we have to catch in the question, it is independent of patient's breathing pattern. Independent. Independent of patient breathing pattern. Right? So when this word is there, independent of patient breathing pattern, then we have to have answer in fixed FiO2 delivering device. The device which can give fixed FiO2 independent of patient's breathing pattern, they can only be the answer. Low flow variable FiO2 delivering device depends on patient's breathing pattern. Depends on patient breathing pattern. So these devices cannot be the answer. Okay. So again, coming back on the question, just by this much knowledge, that between FiO2 0.25 to 0.5 independent of the patient breathing pattern. Simple face mask is low flow variable FiO2 delivering device. NRBM is low flow variable FiO2 delivering device. And Venturi mask is your high flow fixed FiO2. High flow fixed FiO2. So this would be the answer. Rebreathing mask is again low flow variable FiO2 delivery device. So answer will be Venturi mask. Got it? So answer is Venturi mask. Remember guys, this is a mask and with this a tube is attached and there is oxygen flow attached to this tube. This would be Venturi mask. Venturi mask. Right? This tube, this is called Venturi barrel. Venturi barrel. This is called Venturi barrel. And any question can be asked. They can give you the image of the mask and they can ask you to recognize it. If a tube is attached, it is Venturi mask. And if in the mask, the oxygen is opening, attaching here itself, here the oxygen tubing is attaching in the mask itself, then it is a simple face mask. Simple face mask. Okay. And if the mask has a bag attached with it, like this, a bag is attached with it. This is a non-rebreathing mask. Non-rebreathing mask. So again, I am telling you, if it is a face mask and the oxygen tube is attached, opening in the mask itself, the oxygen tube is opening in the mask itself, it is face mask, simple face mask. If it is a mask with a reservoir bag, this is a reservoir bag attached to it, then it is NRM. NRM. Then it is NRM. Got it? Then it is NRM. Okay. And if it is a face mask with a tube attached with it, a barrel attached with it, and into this the oxygen tubing is attached, then it is a Venturi mask. Then it is a Venturi mask. Okay. So I am just making these line diagrams so that it should be crystal clear. Even in the image of the real image, even if different color is given or whatever is given, you have to recognize it just by keeping these things in mind. Okay. Okay. Next question. Acute pancreatitis. Patient is intubated on ventilator with following setting. Tidal volume 420 ml. Respiratory rate 32 beats per minute. PEEP 12. FiO2 0.9. On ABG, pH is 7.33. PCO2 is 48. PO2 is 110. HCO3 is 28. And SPO2 is 100%. Next step in management. So guys, questions on ventilator. Questions on ventilator setting. Ventilator setting. Right? What important thing that we have to keep in mind. Right? First, now in ventilator settings, why do we put a patient on ventilator? For oxygenation and for ventilation. So what are the important settings which maintains the oxygenation and what are the important settings which maintain ventilation? So let's say I have fixed tidal volume of the patient. I have fixed respiratory rate. On both depends minute ventilation. Minute ventilation. And both are responsible for the ventilation of the patient, right? Then I have set the PEEP, positive end expiratory pressure, which keeps the alveoli expanded. This keeps alveoli expanded, right? Now, this is responsible for the oxygenation of the patient. And FiO2, this is also the fractional inspiratory oxygen concentration, the oxygen concentration. Now, this is also responsible for the oxygenation of the patient. So, these two are responsible for oxygenation. So, we need to focus on these two and these two. Tidal volume and respiratory rate for minute ventilation, and PEEP and FiO2 for oxygenation. After always putting a patient on ventilator, after 20 to 30 minutes, we get a ABG done, arterial blood gas analysis done. And 3 values you need to remember. You need to remember the pH, PaCO2 and PaO2 of the patient. Now pH, the normal value is between 7.35 to 7.45. Your PaCO2, remember, 35 to 45. This is the mm of Hg, normal value. And PaO2, everything above 60 mm of Hg is acceptable. Right, everyone? So we need to target on this. So these two tell us about the ventilation, and this tell us about oxygenation. So if patient's PaCO2 is increased, if this is increased above 45, or if pH is decreased, then ventilation has to be increased. Ventilation has to be improved. So either I will increase the tidal volume or I will increase the respiratory rate of the patient, right? If patient's oxygenation is below 60, then we have to improve oxygenation. And for that, I will increase PEEP or I will increase the FiO2. I have to increase the FiO2. Okay. Now let us see this question. In this question, patient's ABG, the pH is 7.33. So 7.33, little acidosis, slight acidosis, but can be accepted. PaCO2 is 48, little higher. So that's why that's respiratory acidosis, little respiratory acidosis. PaO2 is 110, which is quite acceptable. HCO3 is 28 and saturation is 100%. So little oxygenation of the patient is little towards higher side. Okay. Patient's ventilation is what we need to little increase. So it is mostly respiratory acidosis, slight respiratory acidosis. Okay. Decrease FiO2. Okay, we'll come back on this. Decrease respiratory rate. Decreasing respiratory rate will further increase the FiO2 of the further cause the respiratory acidosis, further increase the PaCO2 of the patient. Increase tidal volume. So now this seems correct. If we will increase the tidal volume, the ventilation of the patient will improve. So either this can be the answer or this can be answer. Okay, increase PEEP to 14. Now why PO2 is within normal limit? So we'll increase the PEEP, we'll keep the PEEP whatever PEEP it is, right? So whatever PEEP is it, I will keep it, right? FiO2 is 0.9, PEEP is 12. So this is maintaining the oxygenation. I will try to decrease the FiO2 little, but first, because of the respiratory acidosis, I have to increase the minute ventilation of the patient. So second thing in the setting which I can do, I can increase the tidal volume of the patient. Okay, increase the tidal volume. So this would be the answer. C would be the answer. Got it? So you have to approach any question on the ventilator setting mathematically. Mathematics, pure mathematics. So we will discuss mathematics. Please pay attention. According to mathematics, we have to see the pH and PCO2. This both will tell us about ventilation. And we have to see PaO2, which will tell us about oxygenation. Okay. If pH is less than 7.35 and PaCO2 is more than 45, then ventilation is affected. So we have to either increase respiratory rate or we have to increase the tidal volume. Normally, we fix the tidal volume 6 to 8 ml per kg body weight. If we have increased the respiratory rate up to 30, we will start increasing the tidal volume if it is already 6 to 8 ml per kg body weight, right? Okay, PaO2. we have to PaO2 via oxygenation. So for this, we have to either increase the PEEP or we have to increase the FiO2. So there is something called PEEP FiO2 titration. Something called PEEP FiO2 titration. Now this is important, PEEP FiO2 titration. If we keep FiO2 very high, then risk of oxygen toxicity is there, right? So what we do, we titrate at what minimum PEEP and minimum FiO2, minimum PEEP and minimum FiO2, just adequate ventilation can be achieved. Just adequate ventilation can be achieved. So 0.4 to 0.5 FiO2. We can keep PEEP between 5 to 7 mm of He. So this is FiO2, this is PEEP. Between 0.6 to 0.7, we can keep between 7 to 8 mm of HGP. Between 0.8 to let's say between 0.8 to 0.9, we can keep PEEP between 8 to 10. And if it is 1, FiO2 is 1, then only we increase the PEEP above 10, right? So we try to titrate. Yes, this patient has a very high FiO2 and PEEP of 12, right? And that is only able to maintain the oxygenation of the patient, right? So we will keep it on that, or little we can decrease because patient already has PO2 of 110. But here, clear cut, it is respiratory acidosis. So we will mark that increase the respiratory tidal volume of the patient. If this was within normal limit, I would have decreased the FiO2, right? Because we try to bring the FiO2 to the non-toxic level, and less than 60% of oxygen is non-toxic. So keep this PEEP FiO2 titration thing in mind. 0.4 to 0.5, we keep it between 5 to 7, right? 0.6 to 0.7, 7 to 8, 0.8 to 0.9, 8 to 10, we have to keep PEEP, and 1, we have to keep it 10, right? Okay, next question. Correct sequence for resuscitation. Again, a very popular exam topic, correct sequence of resuscitation. BLS, basic life support, right? Basic life support, right? We need to remember the sequence. So whenever we see a unresponsive, right? Unresponsive patient, right? Now guys, agar ventilator question is you are finding it difficult, but it is coming in your exam. I'm telling you, it may be difficult, but it is coming in your exam. So you have to understand. There is no point in cribbing that I cannot understand. It's a simple mathematics. Okay. So unresponsive patient. Okay. If you have an unresponsive patient, what is the first thing? First thing is scene safety. First is scene safety. Second is call for help. Third is check your pulse and breathing. And if you are not getting pulse and breathing, start compression ventilation. Start with compression and follow it with ventilation. Right? Okay. So assessment, CPR, defibrillation, ACLS, correct sequence of resuscitation. Okay, so we start compression ventilation. We do it till the automated external defibrillator comes. Once AED comes, we manage according to the AED, and then we go for the advanced ACLS support. Then after that, we go for ACLS. So early assessment, CPR, defibrillation, advanced life saving. CPR, then assessment is incorrect. So this is the right option. 13A is the right option. Okay. So remember, for BLS, always scene safety, call for help. Then this is early assessment. This is assessment. Assessment ke baad what is that? CPR. This is CPR. And then this is defibrillation. And after defibrillation, when ACLS team comes over, they take over ACLS. So answer is your A. Sequence is very important. You have to keep in mind. Okay. Now remember, for basic life support, adult, we always give 30 compression to ventilation. 30 compression to ventilation. irrespective of any number of rescuer. So irrespective of any number of rescuer, 1, 2,000, this will be 30:2. It will not change. In children, it is 30:2 and it could be 15:2. 30:2 if it is single rescuer, right? And 15:2 if more than one, right? Always children or infants same or infants same. And who will tell me for neonates? Yes, for neonates. Neonates is the newborn. Neonates is only for newborn. Neonates means newborn, not till 1 month. Infant is less than 1 year excluding newborn, and neonates comes under newborn, and it is 3:1. 3 compression, 1 ventilation. 3:1. 3 compression, 1 ventilation. So we need to remember this. Okay. So always keep in mind. Now one more thing in BLS I want to talk about is that your AED should be used as soon as possible. Automated external defibrillator. External defibrillator is used for BLS. It should be used ASAP. As soon as we get it, we can use it in any phase of cycle we are. Okay, so we have to use it as soon as possible. And accordingly, for shockable rhythm, we have to give shock and do CPR. And for non-shockable rhythm, we have to just do CPR. And we go on doing till ACLS team takes over. So this is our BLS. Got it? Okay. So this is all about this question. Now coming on the next question, 14th. Compression ventilation already I have discussed. In neonate cardiopulmonary resuscitation, remember 3:1, 3:1. So we have already discussed this question. I think this is important. Okay. Next, 15th. During evaluation of emergency patient by primary assessment, all of the following investigation is done except. So primary assessment. Guys, we talked about when we see an unresponsive patient. I talked about when we see unresponsive or let's say unconscious. When some patient seems unconscious, we have to go for BLS assessment. BLS assessment, right? Which we talked in the last question. And if the patient is conscious and emergency, conscious but patient is emergency patient, then we go for primary assessment. Primary assessment, right? So this question is that in primary assessment, all of the following is investigation is done except. First, you need to understand primary assessment, and all of you must be knowing. Primary assessment means A, B, C, D, E, F. This is the, primary assessment, A, B, C, D, E, primary assessment. A for airway, B for breathing, C for circulation, D for disability, E for exposure. In airway, what we do? We assess the patient and we see whether the airway is patent or not. Patency and protection. We see the airway is patent or not and it is protected or not. For breathing, we see the chest movement. And if the chest movement is not adequate, we can do bedside ultrasound. So it can tell us about, if it's a trauma patient, it can tell us about pneumothorax. It can tell us about the pericardial effusion. So bedside ultrasound is very important primary assessment tool. For circulation, we have to see the blood pressure of the patient. We have to see the ECG of the patient, right? So these are investigation which we do for circulation. And we also get a CBC, the complete blood count, the blood investigation done, which will tell us about the anemia present in the patient or not, right? With ultrasound, we can do EFAST, FAST scan, etc. For disability, right? We just clinically evaluate. We do AVPU. We see whether the patient is alert, whether the patient is responsive to voice, whether the patient is responsive to pain, or whether the patient is unresponsive. Right? We don't get a CT scan done. That comes under secondary assessment, which will help us in finding the cause of the problem. Exposure, we expose clinically. We expose clinically and see any site, any kind of problem. Yeah, we can even do GCS for disability, right? So if you see this, chest x-ray will help us in diagnosing immediate condition like pneumothorax, etc. It would be helpful. CT scan is not done for primary assessment. This is done in secondary assessment. Secondary assessment, because this will tell us the cause of the problem, and cause is always what we find in secondary assessment. Bedside ultrasound, it will help us in primary assessment because it will immediately diagnose some clinical conditions which will tell us about the airway breathing of the problem, AV, and even circulation. And blood investigation also is the basic investigation which we do in primary assessment. Primary assessment. So what was the answer? CT scan would be the answer, right? CT we can only shift if the patient is stable. If patient is still unstable, we cannot do CT. So it is not done in primary assessment. Primary assessment always to stabilize A, B, and C. Secondary assessment to find the cause. Secondary assessment, we do further investigation to find the cause. It is done to find the cause. Okay. Okay. So CT cannot be done. CT cannot be done in this patient. Okay. Next question. A 43 years old patient underwent an emergency minor arm repair procedure after car accident. A standard dose of lidocaine was administered near the brachial plexus for peripheral nerve block. So simple, peripheral nerve block was given. All of the following adverse effect can be seen likely to occur after administration except. So they are asking the clinical features of local anesthetic systemic toxicity, or LAST. So they are asking clinical feature of local anesthetic systemic toxicity. Okay guys, local anesthetic systemic toxicity. Very important topic for exam. Now whenever you put a block, you give a block, and if there is a blood vessels and around every nerve, if the drug gets absorbed, then it will cause systemic toxicity, and the following systems can be affected. Mostly two main system is what we have to take care of: CNS and CVS, right? CNS and CVS. Okay, so what would be the clinical feature for CNS? Apprehension. Patient will become very worried. Apprehension. Perioral numbness. Tinnitus. Seizure. These are the clinical feature of CNS. And for CVS, hypotension, then your arrhythmia, and cardiac arrest. This can happen. Because what happens in local anesthetic systemic toxicity? Sodium channel is blocked of brain and heart. Sodium channel is blocked of brain and heart because local anesthetic acts on sodium channel. So we get these kind of symptoms, right? So if you see that what is not to be present, ventricular tachycardia is ventricular arrhythmia, it can be present. Abdominal colic, no guys. Drowsiness, yes, any CNS symptoms can be present. Convulsions, epilepsy can be present, right? So answer is abdominal colic, right? Abdominal colic, remember. Okay guys, management. What is the management of LAST? This is so many times asked. Whatever is the symptom, you need to manage the symptom. You need to manage the symptom and give one antidote. What is the antidote for LAST? Local anesthetic systemic toxicity. What is the antidote we use in LAST? So management is, yes, wonderful, Ritik. So symptomatic management and 20% intralipid emulsion. 20% intralipid emulsion. 20% intralipid emulsion. So this is the drug of choice in LAST, right? So if it is cardiac arrest, what we will do? Who will write in cardiac arrest? What is the symptomatic management of cardiac arrest? What is the symptomatic management of cardiac arrest? Write in the chat box. What is the symptomatic management? Symptom is cardiac arrest. What is the symptomatic management? CPR. CPR plus 20% intralipid emulsion. What is the management of arrhythmia? Antiarrhythmic and 20% intralipid emulsion. So for everything, we will do the symptomatic management and we will give 20% intralipid emulsion. Any signs of your arrhythmia of last seen in the patient. So remember this, okay? Okay. Now coming on 17th question. Okay, guys. A 47-year-old female patient with past history of past medical history of type 2 diabetic mellitus, hyperlipidemia, presents with dizziness and fatigue. On physical examination, her blood pressure is 90/66, respiratory rate is 18, temperature is 98.6, and ECG along the bedside ECG shows this. So in bedside ECG, what we can see, if you see this ECG, what we can see? We can see the heart rate. How many boxes in between two R? That is between two QRS complex. 1, 2, 3, 4, 5, 5.5 big boxes, right? So if I, let's say, divide it to calculate the, let's say, your heart rate, then heart rate of this patient, lot of big boxes between the two, heart rate is less than 60. So in this, heart rate is less than 60 beats per minute. So patient has bradycardia. And bradycardia is producing hypotension. So this is symptomatic bradycardia. So how we will manage symptomatic bradycardia? Yes. Lidocaine is used in tachy. Morphine and verapamil we will never use. It is used in pulmonary edema. Neither this. Answer is oxygen and atropine. So remember, bradycardia, right? Bradycardia less than 60 beats per minute. If it is asymptomatic, observe and do nothing. We don't have to do anything. We just have to observe. If it is symptomatic, that is patient's blood pressure has decreased, right? Patient is becoming consciousness decreased, right? In that case, we will give oxygen and we will give patient atropine. Atropine, the dose, very important from exam point of view. I want you all to remember the dose. Dose is very important. Dose of atropine is 1 milligram per 1 milligram, right? 1 milligram dose we will give, and we can repeat every 3 to 5 minutes. And maximum dose we can give is 5. Maximum dose is 3 milligram. So max dose is 3 milligram, and we can repeat every 3 to 5 minutes. If patient does not respond to the atropine, then we give dopamine. We start either dopamine or adrenaline. These are chronoinotropes. They will increase the heart rate, and they can also increase the blood pressure of the patient. Beta blocker is never used. Beta blocker is used in tachyarrhythmia to decrease the heart rate, right? Okay. And if this also patient doesn't respond to this, then we use transcutaneous pacing. Then we go for pacing. So this is the management. First, atropine. Second, chronoinotrope. And then third is pacing in the sequence, right? So maximum dose is 3 milligram of atropine. We don't give more than 3 milligram. And this is all about bradyarrhythmia management. Okay. Okay. Next question. Now, 18th question. In a patient with ventricular fibrillation, refractory to repeated attempts of defibrillation and epinephrine administration, the most appropriate management is administration of, they're asking, patient of VF. Guys, patient is unresponsive. We did BLS assessment, and in this patient has no pulse, no breathing. Monitor was attached. ECG was attached, and on ECG, what was the rhythm which was seen? It was like this. Let's say something like this. No morphology, nothing. So this is ventricular fibrillation. Ventricular fibrillation. The heart is doing pop, 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 pop like this. Pop, 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 fibrillating. But this is not getting converted into your normal cardiac output. So there is no cardiac output. There is no cardiac output. There is only the heart which is fibrillating. So in this case, we have to, this is a shockable rhythm. Shockable rhythm. So we have to go to the algorithm which manage the shockable rhythm. So how do we manage shockable rhythm of ACLS? So ventricular fibrillation or pulseless ventricular tachyarrhythmia. The first thing we do is give shock. Then we do CPR for 2 minutes. And then again we give shock. And then again we do CPR for 2 minutes. And we give emergency drug. Emergency drug is your adrenaline. Adrenaline. And adrenaline we give 1 in 10,000, 1 milligram. So 1 milligram, 1 in 10,000. This was asked in last exam. So this is a question. What is the concentration of adrenaline used? 1 in 10,000. 1 milligram, 1 in 10,000. We give emergency drug, right? And we keep on doing CPR. Adrenaline we can repeat every 3 to 5 minutes. And again after 2 minutes we see it is the same. VF and VT we can again give shock. And we continue with CPR and we give adrenaline every 3 to 5 minutes. Now the shock is not converting the rhythm, making it into sinus rhythm. Then we can give another emergency drug, amiodarone. Amiodarone, what does it do? It's an antiarrhythmic. It can increase the susceptibility of the heart to the shock. It can make the heart more susceptible to the defibrillation. So there's a possibility after giving amiodarone, the VF gets converted into sinus rhythm. So amiodarone has a huge role in converting and making the heart in VF into the sinus rhythm after giving the shock, because it is antiarrhythmic agent. So this is antiarrhythmic agent, and this increases the susceptibility to defibrillation. So it makes the defibrillation more effective. So if defibrillation is not getting converted, we give amiodarone. What is the dose? Dose again is important. 300 milligram is the first dose, and this first dose, and 150 milligram is the second dose. So we give 2 doses only. We give only 2 doses, 300 milligram and 150 milligram of amiodarone. Got it? So this is for VF and pulseless ventricular tachycardia or tachyarrhythmia. If patient has a straight line or patient has an electrical activity, right? Patient has a electrical activity which is without pulse, and this electrical activity is not VF or VT. Then we call it pulseless electrical activity. And in this, we only do CPR because these are non-shockable. So we only do CPR, and we give adrenaline, ASAP. Adrenaline as soon as possible. 1 milligram, 1 in 10,000. So this is what we do for non-shockable rhythm, nothing else. Remember, no shock, no amiodarone, no amiodarone. Got it? So if the same question was, patient is in asystole and CPR, we are doing CPR, and we have given repeated dose of epinephrine. What is the next dose we will give? Drug we will give. Again, answer would have been epinephrine, nothing else. In non-shockable, CPR, epinephrine, CPR, epinephrine, CPR, epinephrine, nothing else, nothing else. In shockable rhythm, shock, CPR, epinephrine, and amiodarone. Epinephrine every 3 to 5 minutes, amiodarone only 2 doses, not more than 2 doses, not more than 2 doses. So you remember all these things. All these are exam question. Adrenaline dose they have asked. They can also ask you amiodarone dose. So keep the dose of amiodarone in your mind. I don't want you all to make mistakes in doses of emergency drugs. So 3 emergency drug I have discussed till now. Atropine. What is the dose? 1 milligram. Adrenaline, What is the dose? 1 milligram, 1 in 10,000. Amiodarone. What is the dose? 300 milligram first and 150 milligram second. So all three doses you have to remember. Anything can be asked in exam. Okay. Next question. Okay. Which of the following can cause laryngospasm on induction? So now the questions on inhalational agent. Which can cause laryngospasm on induction? Answer is your desflurane, isn't it? Now guys, halothane has good smell. So it is used for induction. So it is used for induction. It's a good agent for induction. Isoflurane has bad smell. Not used for induction. Not used for induction. Sevoflurane has sweet smell. Sweet smell. Sweet smell. Induction agent of choice. Induction agent of choice. And desflurane is a respiratory irritant. It's a respiratory irritant. It's a respiratory irritant, right? And desflurane is known to cause laryngospasm. Known to cause laryngosspasm on induction, right? Known to cause laryngospasm on induction. Got it? So keep it in mind. It is known to cause laryngospasm on induction. Desflurane can cause laryngospasm on induction. Keep it in mind. Okay? SIVO is induction agent of choice. So any question asked for induction, answer would be SIVO. If SIVO is not in the option, answer would be halothane. Because for induction, we need the agent to have good smell. So Rishik, Mohammed, Shanawaz, you all are giving me answer A. Guys, why halothane? Halothane has a good smell, right? It can be used for induction if SIVO is not available. In India, we are so many places using halothane if SIVO is not available, right? Desflurane, the latest agent, is a respiratory irritant and we don't use it for induction. Got it? So remember, sevoflurane is inhalational induction agent of choice. It is inhalational induction agent of choice. Best agent for induction. Right, everyone? It is inhalational agent of choice for neurosurgery. It is inhalational agent used in children most commonly. Why? Because it has a good smell. Okay? Then isoflurane. Isoflurane is inhalational agent of choice for your cardiac surgery, right? And your desflurane not used for induction, but it is best agent for maintenance of anesthesia, right? In obese patient, in old age patient, in renal disease, in liver disease patient, right? So in all these conditions, why? Because it is least lipid soluble and not metabolized in the body. So desflurane is good for maintenance because it is least lipid soluble and not metabolized in body. So least lipid soluble and not metabolized. So these two makes it best agent. Desflurane becomes a very good agent for maintenance of anesthesia. Got it? It's a wonderful agent for maintenance of anesthesia. Remember this. Okay. In obese, old age, renal disease, liver disease. Right? Okay. Now guys, as a bronchodilator, best is halothane best. Second best is sevoflurane. Sevoflurane is second best, right? Halothane is best. Sevo is second best. Keep it in mind, okay? Okay, guys. Which agent needs a vaporizer, right? Which agent needs a special vaporizer? So agent which needs a special vaporizer. Answer is your desflurane. Desflurane has low boiling point and high vapor pressure. High vapor pressure. So it needs a special vaporizer. Got it? Rest of the agent can be given by a similar kind of vaporizer. Desflurane needs a special vaporizer. So Des needs a special. All these are exam question. So this is a question, this is a question, this is a question, this is a question, this is the question, this is the question, this is the question, this is the question. I have discussed with you so many important questions with one question. Okay. Next. Okay. 20th question. Ketamine causes all except dissociative anesthesia, high intracranial pressure, hallucination, drop in blood pressure. Okay, so very simple question again. They have asked a question on ketamine and they have asked causes. I have asked causes all except. Answer is your drop in blood pressure. It's a sympathomimetic drug. It will increase the blood pressure. It will never decrease the blood pressure. Guys, remember, thiopentone, propofol, etomidate, ketamine. These are the 4 most important IV agent which can be asked in exam. Right, everyone? Remember, for central nervous system, CNS, thiopentone, propofol and etomidate, all of these decrease the intracranial pressure. Ketamine increases the intracranial pressure because ketamine is sympathomimetic. It stimulates sympathetic nervous system. It is sympathomimetic, right? Okay. Then for cardiovascular system, thiopentone and propofol, they decrease in blood pressure. They are cardio unstable. Etomidate is the only cardio stable agent, right? And ketamine is sympathomimetic. So it will increase blood pressure, increase heart rate, right? And it is also myocardial depressant. So it is also a cardio unstable agent. So ketamine is also cardio unstable. So remember, ketamine is also cardio unstable. It increases BP, heart rate and myocardial depressant. The only cardio stable agent is etomidate. So this is the star point of etomidate, very important star point. But etomidate is not so often used. Why? Because it causes inhibition of cortisol synthesis. So this point is clear. One more, I will just add, then I will write inhibition of cortisol synthesis. Respiratory system. Guys, remember, all these 3 are bronchodilator, propofol, etomidate and ketamine. Bronchodilator. Thiopentone is bronchoconstrictor. So which is a bronchoconstrictor? Thiopentone. You have to remember it. Okay. Thio, propo, etomidate, ketamine. Now guys, thiopentone, the complication which we need to remember, few complications. Propofol and etomidate can cause pain on injection. Ketamine is a very good analgesic. Okay. Ketamine causes emergence delirium. Patient becomes hallucinated after emerging from ketamine anesthesia, right? And etomidate has one very important black point. It causes adrenal gland suppression. It causes adrenal suppression. So this is the black star point. The red star point was it is cardio-stable etomidate. And the black star point, it is adrenal suppressant. This will be asked in exam. My gut feeling says this question was asked in last NEET and INI-CET. This will be asked in your exam as well. So etomidate causes adrenal suppression. Okay? Ketamine causes emergence delirium, right? And pain on injection is caused by propofol and etomidate. Ketamine is an analgesic. And remember, ketamine produces a very special type of anesthesia, something called dissociative anesthesia. Okay? So if we see the question, then ketamine causes dissociative anesthesia. It increases intracranial tension because it is sympathomimetic. It can cause post-op delirium, hallucination, etc. It never drops the blood pressure. It can increase the blood pressure. So this is false about ketamine. Okay. Now another thing we need to remember, Single dose of any of these agents cause rapid awakening because of the phenomena of redistribution. So remember this word, redistribution. Redistribution. They all show the property of redistribution. So they are short acting because of redistribution. They are short acting because they all get redistributed. And remember, their action is because of lipid solubility, because of their lipid solubility. More the lipid soluble, more is the potent agent. So because of their lipid solubility is their action, right? So more the lipid soluble, more the potent agent is, right? Got it? Okay. No, next question, 21. Okay. Which of the following statement is not true about etomidate? We have already discussed, we just have to see the answers. It is an intravenous anesthetic agent? Yes. We have written it thiopropioetomidate and ketamine. They are IV anesthetic agent. It precipitates coronary insufficiency. Guys, etomidate is cardiostable, so it will not cause any problem on heart. So this is wrong. This is wrong. This is wrong. It inhibits cortisol synthesis? Yes. Can cause pain at injection? Yes. So by one simple chart, few important points we discussed, we have solved both these questions, and both are very important questions. So this would be the answer. This is not true about etomidate. Etomidate can be anything, but it would not be a cardio unstable. So it will not cause coronary insufficiency. So etomidate, one red star, one black star. Red star is, it is cardiac stable, and black star is, it is causes inhibition cortisol synthesis inhibited. So this is most important question according to me. This will be asked in exam somehow, my gut feeling says. Okay, next question. 22nd. A 77-year-old male presents in emergency department with small bowel obstruction requiring emergency exploratory laparotomy. The patient is experiencing significant nausea and vomiting. The patient is prepared for RSI. So rapid sequence induction is what we are preparing the patient for. This is done in emergency surgery. Emergency surgery. Which of the following allows the patient to able to safely receive succinylcholine? Guys, for RSI, rapid sequence induction intubation. Rapid sequence induction intubation. Right? Now, what are the steps of RSI? This is done in emergency surgery. This is done in emergency surgery. And this is done for patient, right, to prevent aspiration, to prevent aspiration. This is done to prevent aspiration. In emergency surgery, to prevent aspiration. So, what are the steps of RSI? Number one, pre-oxygenation. We always pre-oxygenate the patient. So first step is pre-oxygenation. Then we apply pressure on the cricoid cartilage to close the lumen of esophagus. So cricoid pressure, which is also called Sellick's maneuver, And guys, in RSI, we give IV thiopentone for induction plus IV succinylcholine for paralysis. So succinylcholine is most commonly used. Why? Fastest onset. This drug has fastest onset. And then we do not do bag and mask ventilation. No bag and mask ventilation. No bag and mask ventilation. So no bag and mask ventilation, because bag and mask ventilation will promote aspiration. And in emergency surgery, patient is not NPO, so patient can aspirate. So we don't do bag and mask ventilation. And after 30-40 seconds, effect of succinylcholine comes, we intubate. Intubation. So we intubate the patient. So this is the step of RSI. So we use succinylcholine. So they have asked, patient is a trauma patient. Patient is a trauma patient. And in what we can use succinylcholine? Patient has a history of malignant hypothermia. We can never use succinylcholine. Succinylcholine can precipitate malignant hypothermia. So succinylcholine precipitates malignant hypothermia. We may never use it. It's a life-threatening complication. Peaked T wave. means patient has hyperkalemia. Succinylcholine increases potassium, so we will never use succinylcholine. History of burn 6 months back. Well, in burn patient, it can cause hyperkalemia more, exaggerated hyperkalemia. We will not use succinylcholine. In potassium level 3, we can use succinylcholine. It's a normal potassium level. So here we can safely give succinylcholine to the patient. So guys, we need to know what are the side effects or problems with succinylcholine for this solving this question. So side effects of succinylcholine. Number 1, we have already discussed. Succinylcholine can cause fasciculation. In our regular lecture, we have discussed. It can cause post-operative myalgia. We have discussed. It can cause increased in the pressure. It can increase intracranial pressure. It can increase intraocular pressure. It can increase intragastric pressure. All pressures can be increased. It can cause hyperkalemia. It can cause hyperkalemia. It can increase potassium by 0.5 to 1 millicoulomb. Always it can increase. And in some patient, it can increase potassium even more. So it can cause exaggerated hyperkalemia. Exaggerated hyperkalemia. It can cause exaggerated hyperkalemia. In what patient? In burn patient, in trauma patient, in patient with muscle dystrophy, or in patient with muscle disuse as paraplegia. So in all these, we avoid succinylcholine, right? And it can cause bradycardia. Succinylcholine can cause bradycardia. So if patient has a less heart rate, we don't use succinylcholine. And succinylcholine can precipitate malignant hypothermia. It can precipitate malignant hyperthermia. So we never use succinylcholine if patient has a history of malignant hypothermia. So these are the side effects of succinylcholine we have to know. Okay. If I cannot use succinylcholine, what I will use for RSI? I will use rocuronium. The fastest non-depolarizing which is available. Fastest non-depolarizing which is clinically available. Succinyl effect comes in 45 seconds. Rocuronium, the effect comes in your 90 seconds, but faster than other agents, so we can use rocuronium. So it can replace. Rocuronium can replace. And suddenly you are not asking anything in my chat box. Why it is so silent? Huh? Okay, so you are listening. Good. Okay, guys, next question, 23rd question. A 24 years old female develops masseter muscle spasm. After IV succinylcholine, ETCO2 progressively increases, heart rate increases, temperature rises. Management includes all except. So first, we need to make the diagnosis. So what is the diagnosis? So diagnosis is if patient has increased ETCO2, increased heart rate, increased temperature, what is the most probable diagnosis? Malignant hypothermia. So they have asked what we will do in the management of malignant hypothermia. Guys, start halothane. My God, halothane will further precipitate malignant hypothermia. Here succinyl has precipitated and you will further start halothane, it will exacerbate. Halothane and succinylcholine completely contraindicated. Guys, drugs precipitating malignant hypothermia, which can cause malignant hypothermia. Succinylcholine is the first drug. Then your second is halothane, isoflurane, sevoflurane, desflurane. All this can precipitate malignant hypothermia, right? Then your lignocaine, they can precipitate, these drugs can precipitate malignant hypothermia. So never, this is wrong. So this is the first statement which we got is wrong. So this is incorrect. Hyperventilate, yes, to remove the carbon dioxide, we'll hyperventilate. Active cooling, yes, temperature is more, we'll do the active cooling. Acidosis, we'll manage the acidosis. Guys, drug of choice in malignant hypothermia. Management is, number one, stop precipitating agent. Second, give dantrolene. Give dantrolene. Give dantrolene. And third, symptomatic management. Whatever is the symptom, symptomatic management. So guys, this is the management. Dantrolene is drug of choice. And since anesthetic agents are precipitating malignant hypothermia, if a patient with malignant hypothermia comes for surgery, what anesthetic agent we will give? Propofol. Propofol is safe in malignant hypothermia. Safe. All are exam question. Question, 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 and of course the question which I asked. All are exam question. Okay. Now coming on the next 24th. Okay. So which of the following ligament is pierced during lumbar puncture right before entering the epidural space? So they are asking right before entering the epidural space. So before entering the epidural space, what would be the last layer to get pierced? Simple, guys. This is your spinal cord, pia mater, your arachnoid mater, dura mater. These are your spinous process. This is supraspinous. This is intraspinous. This is ligamentum flavum, right? This is the subcutaneous fascia. This is the skin. So this is skin. This is subcutaneous fascia, right? Okay. This is supraspinous. This is interspinous. This is ligamentum flavum. This is dura. This is arachnoid. And this is pia mater. So for entering the subarachnoid space, we have to pierce all these layers. And they're asking before entering the epidural space. Before entering the epidural space, that is outside dura mater. This is the epidural space. This is the subarachnoid space. This is the epidural space. So before entering the epidural space, what is the last layer? Ting, 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 ting. Ligamentum flavum. So what I have pierced is ligamentum flavum, right? So answer would be your ligamentum flavum. Okay? This is the last layer to pierce to enter the epidural space. If the same question was last layer to pierce subarachnoid space, the answer would have been arachnoid mater. So arachnoid mater, right? So I have to enter subarachnoid space. So ting, 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 ting. This arachnoid mater I pierced. I entered subarachnoid space. So answer is for subarachnoid space, arachnoid mater. And guys, if they ask last layer to pierce to enter the cisternae. Cisternae is the other name of dilated subarachnoid space. Dilated subarachnoid space. So again, the answer is your arachnoid mater. Arachnoid mater. Got it? So again, the answer is arachnoid mater. Got it? So I hope you have understood this, right? Okay, guys, remember for spinal anesthesia and for epidural anesthesia, layers are very important. So keep all the layers in your mind. They can ask the sequence wise all the layer. They can ask the sequence wise all the layer. They can ask the last layer to be pierced. So this is very popular question of exam, especially. And one more thing, the spinal anesthesia, which is the best interspace? For spinal anesthesia, the best interspace is below your where the spinal cord terminates, and L3-4. In adult, it terminates at the lower border of L1. So L3, and in some adults, lower border of L2 as well. So L3-4 is considered the best space. I have seen this has been asked quite a few times in your exam, so I'm writing it. Best space. Epidural, we can give in any space. Epidural, any space we can give. We can give cervical, we can give thoracic, we can give lumbar, we can give sacral, we can give any epidural. But this is the best space for subarachnoid space. Got it? Subarachnoid anesthesia, spinal anesthesia. Okay, coming on the last question for the day. Patient was given 1 milligram per kg body weight of rocuronium during RSI. So we talked about RSI previously, that if succinylcholine we cannot give, then if patient is hypokalemia, bradycardia, we cannot give succinylcholine, then we gave rocuronium, very high dose of rocuronium during rapid sequence induction. The anesthesiologist was unable to intubate, but I couldn't put the tube. Now rocuronium is a long-acting one. What we will do immediately? So I'm not able to ventilate the patient. I will give direct reversal agent of Rocuronium, direct reversal agent. I would give a direct reversal agent which will immediately reverse rocuronium, and there's only one drug, Sugama Dex. So answer has to be Sugama Dex. So answer is Sugama Dex should be given immediately. Guys, your reversal agent, right, is divided into indirect and direct. For indirect, which is the indirect reversal agent, is your neostigmine. Neostigmine increases acetylcholine level. So this is only, it helps in reversal in mild block, only in mild block, when the effect of the block is going away. Direct reversal agent is Sugama Dex, and Sugama Dex immediately reverses the rocuronium by binding with it. Sugama Dex directly bind to your rocuronium, and it can also reverse vecuronium. So immediately it binds to rocuronium and vecuronium, and it can immediately reverse it. So it can be used for moderate to severe block. So here we had given rocuronium, and patient, we were not able to intubate. So it is a severe block. What we will do immediately? We'll give Sugama Dex. Has been asked in exam. Expected question of exam. This is expected question of exam. Sugama Dex, remember, our direct reversal agent, immediately to reverse the effect of rocuronium. So immediate reversal agent. Okay, so this was my 25th question. Any question, guys? Apart from what 25 question I have discussed with you, guys, I have discussed with you these 25 questions. We further previously discussed 70-80 questions, right, for the test and discussion part also. Now, please, before exam, just go look through all these questions. I have I have thought too much in my mind and came up with these questions, thinking this could be asked in your exam, right? So I want all of you to, this makes, I think, 100 question of anesthesia, the previous 70, 75, and this 25 question. I want all of you to go through all these questions before your exam once only. I am hoping 10 question of anesthesia would be from this, and you will score 10 out of 10. That is 100%, and will make me proud. So guys, just make me proud, give your best shot, and score 100% in anesthesia. My best wishes for your exam. My good wishes, my best wishes for your exam. Right? So any further question you can put in the chat box. I would very well discuss it, or I'm done. Okay, any question, guys? Any query? Any question? I hope these have been understood. Guys, ventilator question. You please replay this. Again, listen to that ventilator question. I want all of you to go through at least 5 times today only on that ventilator question, and you will be able to solve the ventilator question. It is not difficult. It is mathematics, and all of us has read mathematics. So we will come up with that question. Okay? So remember this. Any query, any question? So I think I'm done. My best wishes for your exam. My fingers will be crossed, and my full support for you in any query, any question. We can again connect on the Telegram group. You can ask me, and I would be very happy to answer all your queries. Thank you so much. Goodbye. Good night.